necessary to keep you updated on the developments in a more prompt way, particularly in the context of yesterday's official start of the registration of 75 years and older for the vaccine rollout, under the vaccine rollout program. We wanted to give you an update which will come shortly. But before we do that, I'm going to use the opportunity to create a context, and we'll ask the Chief Medical Officer to give a quick overview on the numbers. Dr. Jacqueline Bisesa-McKenzie.
Okay, good morning, everyone. I'm going to present the data as of 22nd of March. That was yesterday. First slide. Okay, so yesterday evening we would have confirmed 36,231 cases, of which 760 were imported cases and over 35,000 locally acquired cases. We recorded 542 deaths. The case fatality rate is 1.5%. We have 19.9 deaths per 100,000 population. And if we exclude the imported cases, it would be 19.5 deaths per 100,000 population. The daily positivity rate then would have been 37.1%, with a cumulative positivity rate of 13.6%. Next slide. This is a distribution across the parishes, and you can see that right across the country that we are seeing quite a bit of active cases. Right now, we are recording 6,230 active cases, and by active cases, I mean that cases that would have been confirmed over the last 14 days. Remembering that after 14 days of isolation, persons would have been released if they have no symptoms from isolation. This is what the picture looks right across the country, and you can see that all parishes and most communities within all parishes are affected with active cases, that is, cases that have been confirmed over the last 14 days. This is what our epidemiological curve looks like, and you can see that our numbers continue to increase. And this is the trend right now. We are not yet identifying a peak, so we are still trending upwards in terms of the number of cases. In terms of our positivity rate over the last couple of weeks have continued to increase. Last week we had an overall positivity rate of 38%, 38.9%, and so far for this week we are in the 40s. It's like 40% positivity rate so far for this week. Next slide. In terms of the hospitalizations, the bed occupancy, you can see in blue, and that continues to increase as the number of cases increase. We also see that the number of deaths have also been increasing as the positivity rate increases. So as the positivity rate has increased, we would have seen an increase in hospitalizations and an increase in the number of deaths. Now, just want to look a little bit closer at the numbers in terms of who it is that we are getting the positive cases from. We still are seeing that within the 20 to 29 age group and the 30 to 39 age group is where we're having the most cases being confirmed positive. Now, this suggests that within this age group, there's still quite a bit of movement, quite a bit of exposure and infections. Now, it is important for us to recognize that this is the age group that many persons will not get symptoms. So they do not appear to be COVID positive, and therefore they may not be taking the precautions. They are not adhering to the restrictions, and so therefore the potential of spread to the older age group who they may come into contact with, that is a very real possibility, and that is where we're finding that those persons, although less of them are being infected, the majority of those that are infected that lead to severe illness falls in that age group. Next slide. So therefore, you can see here in terms of the distribution of death by age, that within those age groups, 10 to 19, the 20 to 29, and also in the below 10, that the case fatality rate is low. But these are the age groups that we're having the highest number of positives. However, when you look at the over 69, over 60 age groups, you will see that the case fatality rates are high. So these persons are becoming exposed more than likely through contact with the 20 to 29 and the 30 to 39 age group. And so again, we would want to emphasize that these persons need to adhere to restrictions to decrease the risk of exposure. Next slide. When we look at our risk factors and the comorbidities that are affecting COVID-19 outcomes, we will see that 98.5% of persons of the COVID-related deaths have had one or more comorbidity or risk factor. Most importantly, 73% of persons are 60 years and older. Again, the reason why we would want to have more decrease in movement among this age group, and certainly the other age groups that they would have come in contact with need to take precautions, but also the importance of the vaccination of these age groups. We also see that in terms of cardiovascular disease, diabetes mellitus, and chronic renal disease, that we are seeing persons with a large amount of these diseases. Again, the importance that persons with chronic illnesses make sure that they are taking their medications, that they are controlled, and they're following up with the control of their illnesses. In terms of our hospitalizations, this chart looks briefly at how the hospitalizations have increased over time, and look at our bed capacity that has also increased but now has been surpassed. In the red, we would have seen that we started out in March last year with 22 beds that were dedicated to COVID, and these were full isolation room. Over time, we gave the mandate that all hospitals should have converted wards into COVID beds, and we would have increased to about 380 beds over time. And that increase in the number of beds have kept us above the hospitalizations. So we were never at 100% occupancy of those COVID beds. Even when our numbers went up in September, October, our number of beds were always more. However, you will notice now that as of February, the number of cases that are hospitalized have gone above the beds that we have committed to COVID. And even with the introduction of the Falmouth additional ward and the additional ward at St. Joseph's and a few more spaces, we are still at just about 600 beds that are dedicated to COVID, and our numbers are above that in terms of the hospitalizations. What this means is that persons with COVID are utilizing other beds that we would have used for our general admissions. It therefore decreases the amount of beds that are available to other patients. It also increases the utilization of resources in terms of managing the patients both on the COVID wards as well as on the other wards. A brief look at our reproductive rate. Now, we have been presenting this chart over time, and just again to point out to persons that what happened in between September and October, when our numbers had gone up in August, several restrictions were put in place. And with those restrictions, we had decrease in movement, and that decrease in movement resulted in our reproductive rate going below the 1 level. Now, with that decrease in the reproductive rate, we were able to see a decrease in the numbers of cases. And that was what was able to help us to get the numbers down. Now, you would recognize that after December just about end of November, December, when there was more movement associated with the holidays, the reproductive rate would have started to go up again, and there would have been more movement. By the 8th of February, we would have recognized that our reproductive rate was at 1.3. And measures were introduced at that time to curtail, to try to stop some of the movement that would bring the reproductive rate down. Now, we would have seen that we would have introduced more restrictions on February the 24th. Our reproductive rate now is at 1.1. Next chart. Now, what does that mean? Again, we have been presenting this table over time, but I think a lot of persons have failed to recognize what it means, because this gives us a projection of if we continue at the rate of having a reproductive rate of between 1.2, 1.1, what it is that we will see is a continued increase in the number of cases. Now, this increase in the number of cases, remember that we are already over our hospitalizations. 100% of COVID beds are occupied. If it is that we continue to increase the number of cases, the overall number of active cases in country increases. The number of hospitalizations also increase, and the number of patients with severe, moderately ill, severely ill, critically ill patients also increase. It also means that there is an increased demand for vital resources such as oxygen. So if we do not bring down this reproductive rate, the demand, we are already past maxed, but the demand will continue to increase. How can we bring down that reproductive rate? We bring down that reproductive rate by decreasing movement, decreasing exposure. If persons cannot take it upon themselves to personally restrict themselves, and this is what we would have hoped by this time, that there would have been a certain level of personal responsibility, that persons would be restricting themselves, putting themselves on a personal lockdown so that we would decrease exposure and decrease infection. If it is that we can get these restrictions applied, whether on a personal level or whether it is on a national level, that government has to introduce restrictions, and we can get our reproductive rates down, then our numbers will decrease. Our numbers will decrease, and it will result in hospitalizations decreasing, and also patients with severe illness decreasing, and the number of deaths decreasing. However, if we do not, then the numbers are going to continue to increase. So we have to decrease movements in order to ensure that we are able to get back below the capacity of our hospitals to respond. And what does this mean? Certainly what we have been seeing in terms of our observation surveys is that persons are not wearing masks properly. So many persons are wearing masks, but they're wearing it on their chins and their heads. When we are out on the road, we see persons in taxis that they don't have on their mask. We need to ensure that persons are wearing masks. Our observational studies are showing that 0 to 50%, 51% of persons are wearing masks at any particular time in different parts of the island. Now, this needs to improve. When we do the reports, when persons report their mask wearing, we will notice that many more persons say they are wearing the mask, but they say they're wearing the mask, but they're not wearing the mask properly. That is what we're observing. Many people report that they're always wearing the mask, but still not properly, and therefore still we're having exposure. Next slide. In terms of gatherings, what we have also noticed in a study that was done by Jamaica, the labor force survey, was that 1 in 4 persons are still attending public gatherings, example parties. So that means that if 23% of persons are still attending, that's a considerable number of persons that are still attending gatherings and having opportunity for spread. We had that 1 in 5 persons were attending private gatherings with 15 persons or so. Now, this is also going to result in considerable spread. 1 in 8 persons have been to bars, to nightclubs, and other places of amusement. Now, in December, in the months prior to the survey being done, hundreds of thousands of persons attended public gatherings and private parties. Now, these persons that attend these gatherings are often young persons who tend to have high contact with persons in their age group as well as persons in other age groups. Hence, the numbers that we are seeing with the 20 to 29 and the 30 to 39 having our largest numbers. But we, again, to remind persons that these persons are spreading to the vulnerable population, resulting in illness. Thank you.
Thank you very much, CMO. And I think the information provided by our Chief Medical Officer cannot be more stark. I think it's so important that we recognize that to a large extent, we are in fact our own undoing. We are in fact the cause substantially of the challenges that we're facing. And it's unfortunate. We complain when the restrictions are imposed, the most recent ones seeing a shutdown over the next 3 weekends as announced by the Honorable Prime Minister. But the reality is that these are own goals, these are self-inflicted wounds, and it is extremely costly. It is costing lives. A very important note is that we see our older population who are ending up, for the most part, in our hospitals, caused by them picking up the virus, and in more often than not cases, it's being transmitted via the younger population. The 20 to 29 age group are the ones who are most infected, and the ones who are dying most are those that are over 60. And, I had an experience where one of our health workers, a senior member, actually, I wouldn't say who she is, among the team at the ministry's head office, who said her uncle passed. He never went outside. He never interacted much or at all. But then he contracted COVID based on who interacted with him, and he subsequently passed. Real tragic scenario. So we really have to ask ourselves, are we willing to sacrifice our parents, our grandparents, our aunts, our uncles, our senior family members for the opportunity to mingle without the mask, not obeying the protocols? And so I want to really make an appeal to all Jamaica and our young people that this is as important to you as it is to the rest of us. The healthcare team continue to work very hard in the field, and I want to use the opportunity to recognize them. And they do so at considerable risk. There are some 180 nurses currently infected or otherwise under quarantine currently due to COVID-19, latest statistics that I have gotten, 180, suggesting that our frontline workers are challenged every day because they are the ones who have to work in our hospitals, in the health centers, in the streets, doing whether contact tracing, providing information. And this is why they were first in line for the vaccine. But nevertheless, it's so important to recognize the efforts that they put out every day. I do note sometimes we are critical of some of the programs that they have to implement on the ground. I think we have to also provide encouragement and support to them because, in a sense, they are our soldiers in the field, and they are impacted every day. And they have families who are also affected by the challenges that they face. In other areas of the COVID response, the vaccination program, up to March 20, 10 days into our vaccination efforts, we have vaccinated some 24,502 persons in Jamaica, in the country. And this, of course, with the AstraZeneca vaccine. The number represents some 52% of our target for the month, which is some 47,650. And of course, we're going after 1.9% of our population. Still early days. Our 1.9 million persons. Our first vaccination blitz is set for this Saturday, March 27th, 2021, at the National Arena. Other blitz sites will be operational in due course, and we will announce those. We're looking at the Montego Bay Convention Center in St. James and the Bahe Principe Hotel in St. Anne. So we intend to begin rolling out these blitz centers, which is a phase, the third phase of the three-phase approach, with hopefully another phase to come involving the private sector. But this is the blitz center approach, where we pull together a much larger infrastructure of medical personnel, where our mobilization efforts are a lot more significant, and where we try to vaccinate or set a target to vaccinate some 1,000 Jamaicans. In this instance, this Saturday, we're of course focused primarily on the 75 years and over. And it's important that persons who want to participate in this program, the Blitz, they make their appointments by registering online, the Ministry of Health's website, www.moh.gov.jm, or call the Vaccination Call Center hotline at 888-663-5683. That's 888-663-5683, or 888-1-LOVE. So you can register online, or you can call for registration. Now, this is very important, because what we have happening now at many of our centers is that yesterday, for example, I was at the Good Samaritan facility at Heroes Circle, where the Prime Minister and the opposition leader got vaccinated, among as well as several other persons. And there were so many persons there lining up, some in the sun, because there's not enough place to put them in the shade. And they had no appointment. They just turned up. And it's very challenging for the center management, for the healthcare professionals, to then be managing those who are registered and at the same time trying to control those who are not. It then involves a process of vetting, because we try not to turn away persons if they qualify for the period of vaccination. But it is not an ideal scenario. Not ideal for the persons, because they have to deal with the standing up and the sun hot and the, persons feeling fainty, and you end up have to provide care for them. In this instance, many senior citizens, but also persons who are younger for one reason or another. We appreciate the enthusiasm among that population wanting to be vaccinated, but it does create some amount of challenges, in some instances even confusion, and we would like to discourage it. And so we encourage you to use the appointment system and or wait your turn to be vaccinated. We have to do it in an orderly way. Otherwise, chaos becomes counterproductive and inefficient, and we would rather not have that. So for the Blitz Center that I'm announcing for March 27th, this Saturday, at the National Arena, we encourage persons to go online or call the number. We already have a number of persons who are registered. I'm going to ask the PS to go into that shortly. But if you have not yet done so, please do so. We want to make it as a successful day, where we hope to vaccinate some 1,000 persons. In terms of the online appointment system, yesterday, the preliminary reports that I've had and the final report earlier this morning suggests that it went well. I've seen some persons commenting positively. I've had a few calls and WhatsApp suggesting that there were some glitches, persons couldn't get through. But I think for the most part, it was a good day in that we registered a number of persons. Persons said it took 3 to 5 minutes, and the PS will give better particulars on that. I want to take the opportunity to thank those who were a critical part of this process, the call center, the back office team that had to manage and correct any glitches that came up at short notice. I think it will get better with time, but it did work for a number of persons, literally thousands of persons, and I think it's a good start on which we can build to make it better as we go along. So I'm going to ask the PS to quickly run through what were the first day's findings and results of the registration system for the 75 years and over. A model that we will perfect as we go along and as we add more persons to more categories to the registration process. PS.
Thank you, Minister, and good morning, colleagues and members of the public. So I will first, Minister, give an update on where we are with vaccination in general, and then we will come down to our results from yesterday's launch. Next slide. So for week 1, we achieved 94% of our target for that week, and for week 2, we are already 91%. Today represents the last day of week 2. We began our process on March 10, and so our weeks start from the Wednesday and end the Tuesday of the following week. So week 1, we are 94%, week 2, 91%. Our target for the month is 56. We have achieved 56% of that target, and for the year, we are 1%. So overall, Minister, 26,512 persons have been vaccinated in the population as at yesterday. The majority of the persons vaccinated are females, 60%, males coming in at 40%. Overall, the numbers of persons that have been vaccinated, the majority, because we started with our healthcare workers, our JDF and our JCF officers, the majority of the persons vaccinated fall within the age group 30 to 59. However, closely behind, we have our elderly, 60 and above, where we are seeing over 20%, 25% of that population being vaccinated in terms of the total number of persons vaccinated for the period. Next slide. As expected, Minister, the Kingston and St. Andrew, St. Catherine areas are where we have the majority of the persons who have been vaccinated over time because of the population centers that they represent. And we have our other population centers in St. James and St. Anne coming up with 10% each. So as we said, for this week, we are 91% of our target for March for this week, ending tomorrow, Wednesday. So we should achieve this target within reason. We have vaccinated over 14,000 healthcare workers, which is a good representation of the population. Remember, Minister, we indicated that we wanted to vaccinate 65% of each of our target group. This 14,000 represents 68% of the target group. And so we are seeing where healthcare workers are coming on board and we are seeing quite a number of them coming to the vaccination centers to get inoculated. So of the total population, 55% of the persons vaccinated to date are in healthcare workers. The elderly, 11%. JDF and JCF are 32%. And we have 1.49% of persons that are outside of the group. Some of these persons, as was reported, represent those persons in the first couple of days that were vaccinated because of excess doses that were in the parish, and persons were inoculated based on their presence. We have since resolved this issue, and we believe that we have cauterized this particular problem, and we now have a system in place with the call-out list where only persons within the specific groups that are being vaccinated are vaccinated at the time. Now, starting yesterday at 10 o'clock, we opened our scheduling portal. We have approximately about 31,000 appointment slots that are available for vaccination appointments. And of the 30,000 vaccination slots that are available, or 31,000 vaccination slots, as at 5 a.m. this morning, 4,108 persons have made appointments on the system. So we understand and appreciate that we have still a sizable number of persons that are required to come online. We are encouraging persons, Minister, to use the online portal as the most efficient way. However, we do understand and appreciate that there are some persons in the population, especially in this age group, that would find this particular method challenging. So what we're asking persons who can use online resources to register, to use that portal rather than making calls, and reserve the call center for those persons who do not have the ability to engage in an online registration process. Overall, Kingston and St. Andrew represents the largest number of persons that have made appointments to date. However, there is a small challenge, Minister. We recognize that in St. Catherine, especially in Portmore, we were supposed to have centers operating on the weekends. But because of the implementation of the curfew and the logistic challenge that would have occurred, some of those centers were not available for appointments. We have since recognized this issue, and we will be putting on the system between this afternoon and tomorrow the Greater Portmore Health Center and the Portmore Seventh-day Adventist Church as vaccination sites, and persons as at 3 o'clock today will be able to make appointments at these sites going forward. And that's the Greater Portmore Health Center and the Portmore Seventh-day Adventist Church. So these two sites will be made available to persons once they are loaded on the system. So we encourage persons in the Portmore vicinity, if you went onto the system and recognized that there are no sites, we invite you to go back on the system after 2 o'clock today, and those sites should be available, and you can make your appointments for the Greater Portmore Health Center and the Portmore Seventh-day Adventist Church. Well, as was expected, Minister, the majority of the persons who made appointments yesterday were from the senior citizens group. But we do have some residual healthcare workers from who did not vaccinate last week or the week before, who have made appointments. And we do have some Jamaica Constabulary Force and JDF officers who have also made appointments on the system. But overall, there were at 128,000 hits on our website, on the website for vaccination. The site issued over 15,800 passwords that are persons who actually tried to engage. And the call center fielded approximately 4,000 calls for the day. Now, what this says, especially for the one-time password, that there's a lot of persons, Minister, who are going onto the system who are not in the priority group at this time. And so they would have gone into the system, tried to register, and were not allowed to register because they are not in the priority group that is being identified, which is JCF, JDF, and persons 75 years and over. So what we want to do is to encourage persons to be patient. We are now prioritizing persons 75 years and over, and we want to unclog the system. So we want to encourage persons to, if you're not in any of the groups that are being dealt with at this time, that you do not try to register on the system, because it does create a lot of traffic and slows the ability of other persons who are registered to access and make an appointment. But overall, Minister, with the few glitches in terms of the one-time password that was delayed, we were able to resolve that within 30 minutes, and we were up and running. So overall, I think we had a very good day of the launch of the information system. Thank you very much.
Okay, thank you very much, PS. I think it's my own view is that over 4,000 on day one is a good number, even with the 30,000+ target, and we, would like to encourage, as you have said earlier, persons to observe the notice that is given out in terms of the groups that we're dealing with. The system is not going to allow you to register if you're not part of that group. Now, bear in mind too that we are also pulling from other lists. So the NHF, for example, and even from the health centers. And so those numbers will also increase. All right, I think we should stop here and take any questions that are.
All right. Thank you very much, Minister. Just reminding our media colleagues on the Zoom to use the raised hand feature to pose questions to members on the panel. Okay, we're going to begin with Cassius Watson from Jamaica Social.
Good morning, folks. Are you hearing me?
Yes, good morning. Go ahead, please.
Okay, I have, 3 questions here, basically. The first is to the Chief Medical Officer. Dr. Winter, one of your younger doctors, was quoted in the media as saying that he has been reinfected with COVID-19. Can you verify that? And do you know of any other reinfections in the country? Second question, any signs of the South Africa or Brazilian strains or any other strain in the island? How are those CARFA testings going? And could you give some clarity, please, on the whole issue of the positivity rate that you post on the website daily? The numbers, what are you focusing on there with positivity? Because you give the results from all the tests that are done, but it doesn't seem that your positivity rate reflects all the tests that are done on that particular day. Thank you.
Hi, good morning. So I would not be able to comment on any personal information on anybody in terms of results, whether or not they are true or not. What I can say is that we have had 1 or 2 cases that appear to be reinfections, and those are being investigated. We had indicated before that the possibility of the UK strain being in country could lead to, now that you have 2 strains, which is the regular strain plus the UK strain, it is possible that persons could become infected again with another strain. So that is a possibility, although I don't have any concrete information to say that reinfection was due to a second strain. What we also do know, however, though, that it has been a year since we have had our first case. The immunity, the natural immunity, based on reports, appears to last for up to about 6 months, which suggests that after that, persons could become reinfected. So there is that possibility as well. So while it is that we have only had a few cases reported, which have to be verified to see that they are in fact reinfections, new infections rather, there are possibilities that it could occur. In terms of the South African variant, the samples that are sent to CARFA, CARFA does not just only check for the UK variant, it checks for the South African, the Brazilian variant, as well as the UK variant, and also it does the sequencing that is able to pick up if there are any other new or different strains from what has been reported before. However, I just want to point out that mutations occur frequently, and so you are always going to have new genetic sequences that will come up. However, the significance of them, whether or not they would cause increased infection or increased transmission, or whether it is or not they will cause more severe disease, that is where the significance is. And that is determined over time when you do the investigations, and you will find that. So not all mutations are going to be reported because they are not all significant. In terms of the positivity rate, we have explained this before. In terms that the positivity rate that we use is depending on the positives from the PCR testing and the antigen test that is done in the public sector. And this is because the negatives can be verified. What will happen is that we will have a large number of tests, antigen tests, that are being done in the private sector. And for that set of persons, because it is that there is a high level of false negatives, meaning that the tests are not being done as it should be done in terms of antigen tests have a higher pickup rate in symptomatic persons. What we have are tests being done for traveling in a lot of cases, and these are asymptomatic persons. So you may end up with a negative, but the person may be actually in a very early phase of infection and have low viral load and may actually be positive. But the negatives are not going forward for PCR confirmation. And so because we do not know the correct status of those negatives, we would not use them in the calculation of our positivity rate, because then it would skew the positivity rate to give a false impression that we are having very little infection when in fact we are having higher levels of infection. And on that note, I just want to mention as well that persons that are either contacts or persons that are symptomatic should be seeing their doctor to decide what type of test is being done, to be done. We're having a situation where a lot of persons are going straight to the labs to have the test done. And these are contacts of positive cases. They do an antigen test. They are asymptomatic. The antigen tests are coming back negative. They feel as if they do not have infection, and therefore they are carrying out their business as usual, having all kind of interactions. This will create a problem for us. So if you are a contact or if you are symptomatic, then it is best that you see your doctor to decide what test is appropriate and what precautions you should put in place, rather than just accepting a negative antigen test to say that you do not have disease.
Thank you very much, CMO. I'm going to go to Kirk Wright from TVJ.
So, are you hearing me?
Yes, go ahead, please.
Good. All right. So I remember speaking with the permanent secretary days ago about there's a facility, this medical waste facility that treats infectious materials. Now it's under pressure because of the increased uses of PPEs and so on. And he did say there are some steps that are being taken to remedy the problem, including getting the NSWMA and the private contractor, but he didn't say who the private contractor was. Sir, can you answer the question?
Sure. The private contractor, we're still in procurement, and so I would prefer to await the end of the procurement process, and I will then advise the outcome of the procurement process. So that should not be long. By the end of the week, we will be able to publish that information.
Thank you very much, PS. Want to go to Dion Jackson Miller from RGR?
All right. Thank you so much, PS. Okay. I registered a relative yesterday using the online portal, and it did indeed go very, very smoothly. I had problems when I tried to use the telephone, and all the complaints we've got have been about the telephone system. Given that you've acknowledged that there are quite a few older people who won't be able to register online, what are the plans to improve the telephone registration? That's one. Two, all the experts, I've spoken to several experts, I should say, who believe that testing and contact tracing need to be significantly increased. Is that being considered? And three, are you aware of any deaths resulting in the hospitals from the shortage of oxygen? Thank you.
Yes, you want to deal with the telephone, exactly what the issues are.
So yes, you're absolutely correct. The telephone lines were inundated yesterday with several calls. What we have agreed is that we have a doubling of the number of agents today to absorb the number of calls that are being fielded. So today we will have a doubling of the numbers, and we should have an improvement. By their standard, I think they had 70% call completion. So about 30% of the calls were not attended to. By their standard, that is not, by the call center standard, that is not a good result. So they have increased the number of agents today. They have doubled them. And so we should be in the 90s in terms of call completion by today.
I believe they said they had about 60 or so persons manning phones on the first day.
Yeah, there are
about 60 persons, so doubling would mean over 100. All right. In terms of the testing and contact tracing, CMO, you want to comment on that? The criticisms that we're not testing enough or contact tracing enough. I mean, I think when you have community spread, contact tracing becomes a real challenge. But let me ask the clinician, Dion, to deal with it in a more technical way than I could.
Certainly, we are maintaining a high level of testing still, with over 1,000 or approximately 1,000 samples being done on a daily basis. In terms of the contact tracing, we are doing the contact tracing. It, however, does become more and more difficult as the numbers increase and the staff are shared between contact tracing and manning immunization sites. Really and truly, at this point in the pandemic, where we are in terms of community spread, the ideal situation is that the level of knowledge, the personal responsibility should dictate to persons that they need to adhere to the restrictions. What we are finding in reality is that persons are depending on testing to drive taking precautions. And so we have to continue to test because of this reason. The fact is that the positivity rate is what drives interventions in terms of public health interventions. And regardless of whether we test 500 persons or 1,000 or 2,000 persons, the fact is that if you have a 35%, 40% positivity rate, the public health interventions that you would want to put in place remain the same. It is driven by the positivity rate. But the number of tests at this point, you know, when we have to be concentrating on so many other things, it is really the personal responsibility that should drive personal interventions and not testing. But we're in a sad position that it is the testing that is driving personal restrictions, and therefore we have to maintain this high level of testing that we are trying to keep up with. And the fact is that in terms of the regular surveillance, in terms of our influenza-like illness and our severe acute respiratory illnesses that we are seeing in our health centers and our hospitals, if we were just conducting surveillance and testing on these groups, we would have still gotten the positivity rate and we would have been able to man our resources better. But the continuous driving for contact tracing and testing, you know, where is replacing personal responsibility, and that is unfortunate.
But if I may, Dion, the discussion around experts suggesting that we need to test more and contact trace more, what's the best practices for this kind of initiative at this stage of the pandemic? I mean, I'm trying to sort of reconcile whether they are suggesting that we're not doing the right thing, basically, or we're not optimizing the approach. And I think it's important to sort of, you know, at this phase where you have the community transmission, can you practically be expected to contact trace every outbreak you have? In the case, say, for example, you have 40-odd companies that have outbreaks. Do you have enough workers to go into those entities, or the hundreds of communities across the country? I do recall when we were approaching the different phases, we did say that there would come a point in community transmission where contact tracing is almost rendered redundant in a sense, because you just couldn't practically or physically be contact tracing every outbreak or every positive case. So then you have to resort now to other measures. That's one. And then secondly, the issue of testing. Isn't there a point when optimal levels of testing are achieved in determining the extent of the presence of the virus within the population, in that if you test even more, you still end up getting a rate, productivity or positivity rate, that is reflective of the extent of the virus within the society. Sorry to be a journalist, but I heard a little of the conversation and I'm trying to sort of reconcile what is being said versus our approach.
Right. So pretty much just to repeat what I just said, the fact is that at this point in the pandemic, you need to utilize your resources to the best end. And right now, it takes a lot of resources to do contact tracing and to test. When we are at this stage in the pandemic and the assumption that everybody is positive, that persons should consider themselves to be positive, they should consider everybody they come in contact with as positive, and that should drive the precautions. That should drive people staying at home. What we're seeing is that that is not so. There is not that personal responsibility, and people are depending on test results to tell them that they need to stay home or they need to take precautions. That is unfortunate because it means that we have to maintain the testing to the level that divides our resources, and it is an inefficient use of resources, because at this point in the pandemic, we should be able to depend on our usual methods of surveillance in terms of our influenza-like illness, or SARS, or severe acute respiratory illnesses, and the close contacts, in order to determine our positivity rate and also to manage our patients that are sick. And that is where our testing really should be directed at this point in time. But as I said, because of the low level of personal responsibility, and that we have to be using testing to drive precautions, then we have to maintain the level of testing that we're maintaining. But it is a considerable division of resources that, we would have hoped that we would not be here at this time.
So, again, to simplify the explanation, because I think it's important, there is a point at which further tests or dependence and reliance on testing or contact tracing achieves diminishing returns. And so I do not accept, based on what I have read and seen in terms of the approaches to these things, that the solution is to contact trace more or test more. Sure, we can test more, but as the CMO says, if we do not comply with some of the other issues, then testing is not likely to solve the problem beyond a certain point. And contact tracing becomes impractical because you don't have enough people to contact trace every other person in the population. And that's what community transmission is about. What about the issue around oxygen, the question around oxygen and deaths?
We have not yet received any reports that are going to pin, and it's very difficult to do that. Every death is to be investigated, and where possible, a cause of death would need to be examined. And certainly if there are areas that need to be improved on, then those need to be put in place. But we would not have received any reports specifically saying that we would have had deaths that have been caused by the not having oxygen in the facilities. We have not gotten any official reports where that is concerned. But we are making every effort to ensure that the facilities that are all under, there's a demand, a very real demand in all our facilities, and we have to be working every day to ensure that we have adequate delivery of oxygen so that we can prevent that type of thing from happening where persons can die because they don't have oxygen. We continuously work to prevent this from happening, and all the efforts are being made to ensure that this does not happen.
Thank you very much, CMO. We're going to go to Aladdin Love from CVM.
Morning. Are you hearing me?
Yes, good morning. Go ahead, please.
Right. So I have three questions. First, either the CMO or the health minister can answer. Have we sent any more samples to CARFA to be tested for the UK strain of the virus or any other variant? That's one. Two, testing. When an individual does a PCR test at, let's say, a hospital and then a rapid antigen at a private facility, does the ministry ensure that the results for one person aren't recorded as two positives? And three, just some clarity on how the deaths are recorded. Sometimes there's a note made that a particular death was under investigation? Is it that when we see 12 or 13 persons dying, 12 or 13 persons actually died in one day, or they died previously, but their death was recorded on that particular day? That's it.
Simo, I think. Huh? The second one is about testing and double counting, and then deaths when they are recorded versus when they die.
Right. Okay. So we have not sent off any samples as yet. My understanding are that samples are to go off this week. In terms of the double counting, yes, we do ensure that anybody that comes up as positive, there is a check within the database to ensure that it is not counted twice. So this is, and somebody had asked earlier about persons being reinfected or having new infections. So we go through the process to ensure that there is no double counting. Where it is that you may see a name comes up twice, then that is when investigations are done to find out, is this an error? Is a person being tested when they're within the same time period of having an infection, they have not gotten better as yet, or is this a new infection? So it is a continuous process, and that is why sometimes, it takes a while for us to get the results out, because we have to double check on every case, every positive case, to make sure that it is not repeated, and that if it is repeated, if it is a positive from before, why is it so? In terms of the deaths, so we report on the deaths when we receive the notification of the death. So the deaths occur within the hospitals, within the field, and the notifications are sent to us. We will not get the notification of a death necessarily on the same day that the person dies. So if a person dies today, we may get a notification tomorrow. So it is not the same day that we will get the notification. The other thing is that investigation is done at the level of the service delivery site. And so what may occur as a death today, it may take a bit of investigation, check results to see if this person was COVID positive. And so it may take more than one day for them to make the notification as a possibility of a COVID death. Once we get the notifications of the death, then we have to do further investigation, because sometimes the information is not clear, whether it is that the person died from a comorbidity, whether there was another incident that caused the death, so the person may have COVID, but have a COVID positive test, but the cause of death is not COVID. So sometimes that investigation, sometimes it's very straightforward. And as we get the information, all the information is there, and we can classify the death. But sometimes it is not clear, and it falls into the group where you see death under investigation. And sometimes it remains there for a while because we have to wait for the reports, the notes from the hospital to come in to review. So that is why you will see, for example, that 6 deaths reported, and the deaths occurred between, say, the 6th of March and the 11th of March. That's why you will see reports like that.
Thank you very much. CMO, we're going to go to Zara Burton.
Good morning, everybody. I have several questions, and I would like to be allowed to ask all of them because I was skipped at the last press conference. There are about 4 for the CMO, and there are about 2 or 3 for the permanent secretary or the minister. So the CMO first questions, any severe adverse reactions of the 24,512 persons that have been vaccinated? Second question, like Deron Wood, who reportedly had a vaccine, had seemingly anyway, some pre-existing conditions, had tested positive for COVID. You were just mentioning a while ago that cause of death sometimes is under investigation. Is there any kind of word on, just because he's a counselor, what led to his death as yet? And how do you go about determining in a situation like that what killed the person, whether all or one or some had to do with a death where it is kind of complicated? That's 2. My third question for the CMO: how many persons like Deron Wood that have had the vaccination, even though the vaccination may not have caused the death, but just have had the vaccination, how many persons have died after having it? 4 for the CMO, final one for the CMO. In a press conference on March 8th, this is with the Prime Minister. This is your quote. This is in regard to PPEs. You said, we really made an effort coming into the end of the year to ensure that where we had stockpiled quite a bit of protective equipment, personal protective equipment in preparation for the surge. I want to understand that last line. When you said that, is it that you were expecting this kind of surge in the COVID cases in the hospital system? So those are my questions for the CMO. For the PS or the Minister, will the government set up a vaccine severe adverse reporting system that will be formally set up? Also, let's say a person has a severe adverse reaction, just for the record of what we're going through right now and for the education of the public, is the government going to be covering the cost, let us say, for any kind of medical costs that would occur as a result for those individuals?
All right, thanks, Zara.
All right. In terms of the reporting of the severe and adverse events, so there is a reporting system that is in place. This is not new to us. Persons can look at on our website, and there is a button to click to report any events associated with vaccination. So our reporting system feeds into an international system for all vaccine-related events. So we collect the data, and we have it. It is reported in the report that the Permanent Secretary gives, and it is also reported on an international level, because internationally you want to see what are the possible effects of the vaccine, so that everybody can learn from what happens. We have not had any reports outside of this one case of any deaths that would have occurred after vaccination. I just want to say, though, that the vaccine does not protect you from all the reasons that persons can possibly die. And so you will find, especially, we saw in Norway, where when they had vaccinated several of their very elderly, very frail persons, that there was a report that there were deaths that occurred after vaccination. But then, the investigation showed that, these persons had their situation in terms of age, in terms of comorbidities, would have led to death, and the death was not because of the vaccine. So while it is that as more and more persons become vaccinated, you are going to have that persons will die from other causes, and coincidentally they would have the vaccine. But the establishment of a cause relation to say that the vaccine caused the death, we certainly, nationally, internationally, we have seen that there has been nothing that have said that taking the vaccine would have caused death. As a matter of fact, one of the reasons for giving the vaccine in terms of the trials is that the vaccines prevented severe manifestations of the illnesses and deaths, and that was 100% in all the trials for all the vaccines that we have presently. In terms of, persons who, first of all, the vaccine is not the virus. There's no live virus, so that the vaccine cannot cause COVID. Okay? So persons who have a positive COVID test after taking the vaccine usually would have been exposed either just before they had the vaccine or just after they had the vaccine. So they would have been exposed and would have become infected. And their outcome is going to be dependent on all the risk factors that they personally have. But the vaccine does not contain any live virus, and you cannot get a COVID infection as a result of taking the vaccine. So I just want to clarify that. In terms of the statement made on March the 8th, in terms of the stockpiling of resources, remember that from in November, we had made a projection that we were going to be seeing an increase in the number of cases coming after December because of the increased movement that was anticipated in December. So in preparation for that, we had directed all the donations that we were getting into the regions in order for them to have a buffer stock outside of what was coming to them on a regular basis through the National Health Fund.
The other question, Ms. Burton, regarding the covering of the cost for the medical costs for persons who would have severe or adverse reactions to vaccination. Do recall that the current policy of the government is a no user fee at the point of service delivery. And so all citizens avail themselves of medical care free of cost at the point of service delivery in the public system. And so it's a logical flow then that we would, once someone becomes ill for whatever reason, that the cost of their medical attention will be borne by the public system.
Thank you very much, PS. We're going to go to Owen Brown from Roots FM.
Yes, good morning. Good morning. Yes, I have several questions. It's regarding the testing. The CMO actually explained the process if persons report for like doubling and all of that. But what I wanted to know, what's the turnaround time for a positive case to actually be reported? Because I know of cases where persons, they did the test, some 3-4 weeks, and they were waiting for the results. They had to go back to work because they have not received any result, and they're, to some extent, recovered. With the positive that you're receiving, how is it? We can say then that of the, say, 18,000 active cases, that these are persons who actually have the virus now, as opposed to when the numbers are coming in, some of these persons have recovered already based on the time the positive took to come in. How can we, here in Jamaica now, know that, all right, if we see 18,000 active, we know that these are actually active. So the turnaround time we want to know, essentially, with some of these.
Just to answer that
for the vaccines.
To answer that quickly, what we use in the epidemiological curve is the date of onset of the illness. So if persons, even if you are tested today and you don't get back your result, say 3 days later, it's not the 3 days later that is reported as your case date. Your case date is the date of onset of your symptoms. So if your onset of symptoms was 1 week before you did the test, then that's when whether you're an active case or not starts from. For those persons who do the test and don't report any symptoms, or they don't report a date of onset, we use the date that they did the test, not the date of the results. The date of the results are never used.
All right, Owen, we'll allow one last question from you.
All right, great. Right, for the vaccine, so for the take-up, say of the vaccines that we receive, some 60, we have say probably 40% still left back based on persons who are not taking up or going forward to take the vaccine. What would be done with the vaccines that are left?
Reserve list.
If the leftover vaccines,
At the end of the day.
no, at the end of the day,
Yes.
no, not at the end of the day. Oh no, we remember that we have a rolling list. So right now we are prioritizing. So we last week and the week before we prioritized healthcare workers, JDF, JCF. Recall also that we have received 50,000 from India and approximately 14,000 from COVAX. So our complete supply is 64,000 at this time. So as we go through the list, the different priority groups, we roll out the vaccination program. So right now we are not anticipating any leftovers per se. We just move from one group to the next and we vaccinate as we go through.
Thank you very much, P.S. Just going to allow for two more questions quickly from Nadine Wilson-Harris from the Gleaner.
Hi, good morning. Just clarifying, P.S. In response to Zara's question about the reactions to the vaccination, you were speaking about the access to public health care and persons can avail themselves to that. Is it a case whereby persons are having a reaction and they go to their private medical facility and they do incur a cost? Who would stand the expense for that?
Well, no. If you believe that you're have a reaction and you go to your private facility practitioner, then there's a referral system, because then you'd have to be referred into the public system for analysis and treatment, and whatever cost associated with your being attended to in the public system would fall within the remit of the resources that are available in the public health system.
Thank you, Pierce. We're going to go to Ricardo Brooks from Nationwide.
Thank you, Stephen. Good morning. Permanent Secretary, could you say whether or not you have received the findings of the report of the missing vial from the Cornwall Regional Hospital? And if you have, what are the key takeaways from that report?
Thank you for the question. So the Ministry of Health and Wellness have completed the audit. The report is with us in executive management and has been circulated for management response. Now, the process around audit is that the audit findings are discussed, and after the audit is tabled, management has to provide explanation to some of the findings in the audit. I must also report that the police have begun their own investigation into the vial, and they are also preparing their own report and to determine whether or not any criminal charges will be laid.
Thank you very much, Pierce. And that is the time that we have allotted for our questions from the media. Let's apologize to our other colleagues who are not able to ask. We're going to go back to Minister for his closing remarks.
Okay, thank you very much. I think we all have meetings that we have to move on to, so I want to just be brief to thank those who came online. We will continue to provide you with updates as they become available, and just to remind our Jamaicans to please observe the protocols, follow the information that we provide as it relates to the categories for vaccination, and let us please work together to ensure that we respond effectively and efficiently to the COVID-19 virus. So thank those who have made this morning possible, and we will continue to keep in touch. Thank you very much.
March 10th, 2020 was the day COVID-19 turned our lives upside down. But thankfully, March 10th, 2021 was the day we got hope that the pandemic will end. With the COVID-19 vaccine now being available to Jamaicans across the island, it means that very soon we can get back to normal. These vaccines are both safe and effective and will ensure that you and your loved ones are protected and can get back to the things you love most, like partying, going to church, like family dinners, like simply giving your mom or dad a hug. I have been vaccinated and I am encouraging each and every Jamaican to take the vaccine when it is available to your group. Let us put a stop to the COVID-19 pandemic. Let us get vaccinated so we can get back to life.
What if they knew that you abused her? Her family?
Mr. Jones.
And your colleagues, how will they look at an abuser? When the law comes knocking, you'll have nowhere to run.
Mr. Brown, you're under arrest. Please get up, hands behind your head and interlock your fingers.
Turn your back on abusers. Report gender-based violence to the police. There's no excuse for abuse. Call the Bureau of Gender Affairs at 876-754-8577.
Pedestrians must be careful before crossing the road, especially at nights.